Welcome to Real Wealth Podcast. This is Mike Proctor, and I am your host, sponsored by Leading Edge Financial Planning. I'm here with Dr. Elisha Yaghmai, who's a med-peds doc, and he graduated from Harvard with his undergrad and went to University of Kansas for his internal medicine and pediatrics education. He also went to UT, and he's very well studied. He's an entrepreneur. He founded FREESTATE HEALTHCARE several years back. He's been my doctor for a little while, and it's been fun to watch the evolution of the practice and the app and all the fights and struggles of getting telemedicine going in Kansas. So today we have the privilege of being able to talk to him and learn more about what that looks like to start a business in the medical world from the ground up here in Kansas. As always, our focus is learn how to live the best life possible at the time we have left. So we'll get to hear both the ends of that and get to learn more about Dr. Yaghmai today. So welcome on, Dr. Yaghmai. I'd love to hear just a little bit more about what is it your practice does and why did you create it? Why'd you come up with FREESTATE HEALTHCARE?
Sure. We do two different things. And the place we started was actually providing medical services to underserved rural communities in Kansas. That was the initial impetus. So the story was, at the time this was started, I was working at a tertiary quaternary referral center up in the Pacific Northwest. Been doing that for a few years, and the easiest way to describe that was medically. I mean, it was interesting. You'd see interesting cases, and, do work that from a medical perspective was interesting or valuable. But in the broader sense, it was the epitome of sort of what the modern healthcare delivery system has become. So after some years of doing that, the easiest way to describe it is that I would just come home angry every day because of what it was we were doing to people, mostly in the name of insurance payment. It had really very little to do with trying to do the best for them, and it had everything to do with the business imperatives of trying to run a healthcare entity. And that was a nonprofit system, so it wasn't even the for-profit motivation per se that people are more suspicious of. They were just trying to make the place successful and keep the lights on and keep things running and make their venture successful. And there were a lot of things that were being done, even then, that were not consistent with what I think the general public would want from their healthcare entity in reality, if they knew it was going on. And these are things that are, kind of well known within the industry and are usually not that well known outside the industry. So anyway, after some years of that, I wanted to do something that I felt had more value in it. So I had done a little bit of work in rural Kansas before because I trained here, I did my residency here. So I wanted to start going back to help out rural communities. The problem was that at the time my wife was still in training, I had a young child. I couldn't just go flying all over the country to do the traditional thing, flying into communities and help out for a week. So that led to me thinking about the possibilities with virtual care, which at that time, this was back in 2014, was much less developed than it is now. There was, minimal. There was some technology, but it was very expensive. You usually had to get a grant to even begin to afford something like that. It was not very flexible in the sense that it was a camera on a wall. It couldn't move around very easily. So there were a lot of barriers to actually doing that. So as I got into it, I initially came up with a quick little model using some cheap consumer-grade electronics at the time to basically do the same thing as the $150,000 systems, which sounds counterintuitive, but like a lot of things where you start off with kind of a legacy thing and then the technology kind of catches up in the meantime. It's one of those type situations. So the tech had quietly caught up with the need, but nobody knew it because they were so used to the legacy equipment, right? So in their minds, they're like, telemedicine is a $150,000 investment. Therefore, I can't do telemedicine. Therefore, I don't care about it. So I'm not paying any attention to what's going on in that area. I just happened to walk into it at the right time when the processors and the devices had gotten faster and, Skype was more popular and, people were beginning to FaceTime more often. All that stuff is kind of going on. And so it was in that world that it suddenly became apparent, hey, you can cobble together a couple of different things that weren't necessarily made as part of the same platform. They were all sort of made separately, but we could stick all these together in a sort of Frankensteins monster of technology, and we could actually get the outcome we want, which is the ability to do a remote examination and interview our patients and do all the stuff that we would do in person, but we could do it virtually, and we could do it for a tiny fraction of the original cost. So, by the end of that, so I pulled in a colleague of mine that had got an engineering degree in his former life, so he kind of did a deeper dive into the tech, and we came out the other side of that after some experimentation, a lot of research and playing around with a system, that did the same thing for, at the time, about $1,000. The cheapest product in the market at that time that did anything like it was about $25,000 to $35,000, and the kind of gold standard at the time was about $60,000 to up to $150,000, which was the old systems, the Polycom systems, if anybody knows about those. So that was kind of that was the beginning. It was like, okay, we know that rural communities have a need. That's, everyone's known that for a long time, right? Not enough doctors, can't get staffing. So that was established. Then it was, okay, we can use technology to bridge those gaps in ways we weren't able to do before. So rather than me flying all over the place, who cares, right? I just send you an iPad or something, right? And I can be available in your community on a moment's notice for a much lower price because I don't have all the travel and having to stay and all the things that are there. That was the basic idea. And so, I mean, it was an ironic situation because you'd have to have been there at the time. Like, this was a huge thing that was happening very quietly. We're sitting there and we're like, man, I can listen to the heart on the internet, and I can do it for a tiny price. I can do it for a few $100s. I can do this. $1,000, I can do everything. I can do everything. I can look in your ears. I can look in your nose. I can look in your throat. I can listen to your heart and lungs. I can do a full exam on you. Like, this is amazing. And so at that moment, we had a kind of George Bush on the battleship type.
Yeah. In what keeps coming to mind is we're in a post-COVID world now.
Yeah.
Where it's normalized.
Yeah, now it is. Yeah.
Now it's normalized. Everyone's like, I don't care. But this is 2014.
Yeah.
So go back to your George Bush.
Yeah. No, it was like, we figured out access. We just solved access to care. This is amazing. Like, you can put a doctor anywhere in the world that has the internet. We can put a doctor there, right? So all this stuff, all these mission trips and all these other things that we do, right? Where we're spending all this money, and if it's hard to get people, and the whole locum tenens industry where they charge you $300 an hour to send somebody out to watch movies and see 3 patients, I'm like, It's all over, right? It's all over. There's so much savings we can generate. We can do better care because, now you can have, rather than needing to go to, the Mayo Clinic to get access to the specialist, like the specialist can just see you, right? Virtually, wherever you are, right? And they can do it instantly as opposed to waiting 6 months until, it was just all that stuff was just there. And so we were like, we did it. Like, we fixed this thing. We solved it. This is fantastic. Like, we're going to go change all this stuff. And then we ran into reality, right? Which is that no one cared. And not only did no one care, in many cases, they were actively opposed to it. Because it was different. It was just not what they were used to. And so, they would rather pay the $300 an hour and have somebody go out there to do nothing than pay a tiny fraction of that amount to have, a whole stable of physicians be readily available, right? So it was the strangest. I mean, even now, on, human psychology, you get it, but it was still weird. So that was the initial thing. And so as part of that impetus, we went out, recruited a bunch of docs. So we had to start, this is no joke, we went out, we got 30-something sites signed up. We had 25 specialties available at that time. We were giving the technology away for free because we'd done pro formas out, and we were like, look, you just have your patients come see us. Like, that's, when they have a problem.
Right.
Just refer them to see the endocrinologist or internal medicine, whatever you need, right? We have it all. Like, we had all of it, right? So just roll it in. Doesn't even cost you anything to do this, right? And if you do that, it will pay for itself because it's so cheap to roll out, right? It'll just pay for itself. And none of that worked. Mm-hmm. Precisely none of it worked. And it didn't work because the insurance companies had no interest in paying for it. Not only do they not have no interest in paying for it, they were aggressively against it. So it wasn't even like benign neglect. It was like, no, we hate you and we want you to die.
Right.
So that led to a whole, additional saga, which I'll spare you. But kind of to close out, I think your initial question of what do we actually do, that led to a second iteration. So about 2016, 17, it became very clear to us that it didn't really matter what arguments we made. It didn't matter what data we presented. It didn't matter how many great stories we told about all the wonderful things that are being done to try to help people's health out in rural Kansas. That was irrelevant. Nobody cared.
Right.
So what were we going to do? And so we were sitting at that time on a tech platform that worked, but what do we do with it? Because people won't let us use it. I mean, literally won't let us use it. And it was not patients, mind you. It was not patients that were rejecting it. It was their primary care providers that were just suspicious of this whole virtual medicine thing. It was the insurance companies that wouldn't pay for any of it. It was hospitals that were like, I just don't even know what you're talking about, and I don't want to know what you're talking about. I mean, it's just all that, right? So the decision was being made for the patients by a bunch of people that were not actually the patients. So our thought at that point was, well, why don't we just try and roll some of these things out to people directly? Instead, I mean, we have the tech platform. Why don't we try to do that? So that's actually where the concept of the cash pay practice came from. We didn't invent that by any means, but that was where we thought, okay, well, we can't do insurance, so let's try to go around it.
Just as a business model.
Like we need a way to get this stuff paid for. Like it has to, we can't ask people to work for free. So let's develop a cash pay model. So we took initial lessons from kind of the direct primary care movement. We talked to, there's some local docs that are very well known for that, right? And we talked to them about it, got a lot of insight from them about how it was all put together and how it was structured, thought it was a fantastic concept, and began to roll that out. And then I would say, partway through that rollout, just begin to think, hey, this is a cool concept. It doesn't do everything that we would want it to do, meaning in the structure that it was at the time, it's still mostly a viable option for people that already have discretionary income on some level. It's, it can fit in people that don't have as much, but it's not a great fit for that because of some of the charges and things that went on. Like the issue was, okay, we can take care of a lot of your front-end needs. That's true.
Right.
But if you need a complex surgery, or if you get cancer, right? If you have something else that happens that we find, you're back in the insurance and hospital system. So that led to a lot of just kind of thinking and searching on our part to try to figure out how to reconcile those things. And I think we're still in that process of sort of evolving around that to, number one, make it affordable for everybody. And then number two, figure out how do we solve those downstream issues? Because I think the realization that many people have at this point is that healthcare costs too much. It's just too expensive, and it's becoming a huge problem for major sectors of the whole country.
Right.
But what do you do to solve it? There have been various solutions obviously proposed, none implemented. But that was the secondary piece. So all of that monologue is to say we still have a practice in which we do two things. We work on the one hand with rural communities, trying to help them solve issues with access to care. And then on the other hand, we have within Wichita a practice, which I'll describe at least as a technology-enabled practice that is really predicated on the idea of trying to provide affordable care, but not in the sense that most people think of with that. When they think of affordable care, a lot of times they're thinking of, okay, this is maybe like an FQHC type situation, right? It's federally subsidized programs or something along those lines. What we're trying to get to is more like, how do you make healthcare more like food? It's a thing everyone needs. You need it all the time. Is there an economic model where you don't need food insurance, right? To pay for food, you just go to the store and buy the food you need, right? And there's food at different prices, but you can usually get basic food in most cases, right? How do we get to that? How do we get to food or clothes or other necessities that are within reach of most people most of the time? And is there a way to do that? We don't have all the details of that worked out, but that's kind of the other piece of that we continue to try to chip away at.
Right. Yeah. And in the industry, it became so apparent when you were launching into this. And I think one day we wound up, I think you've worked it out better than this, but we tried to get an X-ray or maybe it's an MRI.
Yeah.
And we drove like to 3 different places and we're like, no, we're here to pay in cash. And you guys said it was going to be this much. Like, oh, we don't do that. Yeah. I don't know what you're talking about. And it was just such a fiasco is what it turned into.
Yeah, no, that's absolutely the case. I mean, kind of in both scenarios, we had the same experience, which is that we're just speaking a different language. It was the same. We'd go to some communities and we'd say like, we got these virtual doctors, right? And they're just the same as like a doctor that you'd love to have them out here. It's just the same. It's just they're just on the computer. They still do an exam. They still interview you and. Folks would look at us and be like, what are you even talking about? Like, I don't even know what that is. I can't even imagine what this is, right? And it was similar. So you're talking about cash pricing and people are like, cash price, like, just put your insurance card down. We're like, no, that's the whole idea.
Can I just give you money?
Yeah. Yeah. Right. Like I would in almost any other business, can I just pay you for your service?
Right. And then we don't have to fight for the next 6 months about you trying to overbill insurance.
Right, exactly.
And insurance not wanting to pay it. And then,
just that whole, right. No, that's it. Hey, my doctor, ordered a study and feels it's necessary, and I agree, and I'd like to pay for it.
Yeah.
Rather than no, we need to get you need to have 6 weeks of this first, and then we need a prior authorization process, or.
And I think that might even get back to some of your people need healthcare.
Yeah.
And we don't need this to be a $150,000 expense. It can be $1,000 just for the equipment we need to get it done. And we can cut out the bureaucracy of insurance in the middle.
Yeah.
And just do what we need to do rather than follow all their A to Z steps in order to get paid.
I mean, the problem with the A to Z steps, right? It's a weird thing. So a lot of folks, tend to sort of villainize insurance in this process, right? And I think when we started off, we kind of felt that way, particularly coming out of the whole rural experience, where we were like, y'all are being ridiculous about this. Like we can save you a $30,000 life flight if you'll pay for a $75 visit. We're just going to do it online, right? Again, now they do all this stuff, so it doesn't matter.
Right.
But at the time, this is what was going on. So we're like, so you're saying that we need to spend the $30,000 to fly this person from Western Kansas to Wichita to see a specialist that could have just seen them in the hospital there. I mean, that's why they're coming here. They're coming here to see a cognitive specialist, right? It's not like they're going to do surgery on them. They just need to look at their data. They could have looked at their data there, but you won't allow us to do that, so we have to fly them. That's not good for the patient. It's not good for you either, right? I mean, you're spending a bunch of money you don't need to spend. But coming out of that, I think we had that sort of more negative, I think, thought. But, it's like over time, it's what role do those entities play? For the most part, it's kind of, it's checking people's bad impulses to a large degree, right? You have the doctor that's going to do too much of a procedure, right? Knowing very well that patients don't need it because they get paid to do that, right?
Right.
You have that kind of thing that's going to go on. They're going to overprescribe this or underdo that or whatever it is. And so the insurance kind of steps into that in the role of kind of protector of whatever it is, protector of the individual or the public interest or whatever the case. Obviously, they have their own interest in it as an organization, but that's kind of part of the role of what they're there to do. They're there to, quote unquote, manage the care. But at the same time, the thought has occurred to me, okay, part of the problem here is that the pricing itself is so high. In other words, if I get paid thousands of dollars to do this procedure, then if I'm an unscrupulous person, I may be tempted to do more and more and more and more of it, right? Mm-hmm. But I couldn't charge thousands of dollars per procedure if I was charging you, the individual, for it. Right. I only get away with that because I'm charging a massive $1 billion conglomerate, and I know they have the money to pay me that, right? It's not, and again, with healthcare, the cost is often dissociated, or I should say the price is dissociated from the cost, right? It's not,
right.
It costs you, that bag of saline they charge you $300 for on your hospital bill, cost them $1, right, to get. It's not cost plus, it's not cost plus profit margin. I think most of us could at least understand, okay, yeah, you need a profit margin, right, to continue to operate and expand, right? But this is not that, right? This is just whatever the price of the thing is, and then there's just some other number, right? Mm-hmm. Which seems to have just been made up in many cases. It doesn't obviously correlate. Somewhere in there, right, is the problem. So it's like, okay, I get paid this price because I'm charging a $1 billion conglomerate, not the individual. The individual would never be able to pay me this price. So I would have to bring my price down, which in turn might change, even if I have no ethics at all, it might change my own behavior, right? Because now I'm making $200, right, per procedure, not $3,000 per procedure. Those are some of the things, right, that go on in this. Now, there are others that would also have to be factored in, but it's the system as constructed kind of creates its own imperatives and creates its own behaviors. Mm-hmm. And those are assumed at this point to be the truth, like that's the only way it can be. And that's not actually true if you investigate it in more detail or think through what other ways many of these details of healthcare could be handled. That's the fundamental problem. But that is getting people past that. So kind of, again, like, alluding back to your experience, getting people past that is difficult because it's been decades and decades of conditioning into this is how we do this here. And you walk in and say, well, we don't have to do this that way at all. And that's difficult. That's difficult for folks to get around.
Let's talk a little bit about, you made a comment when we were talking a couple months back about how every system is perfectly designed to produce the outcome that you wind up with.
Mm-hmm. Not my quote, by the way. But
okay, fine. Fine. We're talking on the phone. And that's,
yeah.
Yeah. No, but
right.
It fits.
Yep.
And it makes sense because You set out to create a practice that was going to revolutionize healthcare, Western medicine. You've done that in a lot of ways. You've helped get legislation passed. You've helped get insurance companies to adopt and adapt to remote healthcare.
Yep.
But the reality is you feel like you set out to build a car and you wound up with a faster horse.
Yeah. Mm-hmm.
So what played into that?
Okay, the short answer is because we didn't have enough capital to do the whole thing. Because to do it, you would need to stand up a completely alternative system. I mean, to do it all the way, right? You would need to set up a whole cache. You need the hospital, you need all the testing, right? You need the doctors.
Everybody's got to be on board.
Everybody's got to be on board from top to bottom in the entire system, and you set up a competing system that works on a cash pay basis. That actually could work, but it's very capital intensive to do. If you don't have that kind of money lying around at the beginning of the thing, you have to, chop a lot of wood, right, to get there. You have to kind of slowly implement pieces of it as you're able to put together the funds to do that. That's part of the problem. Until you can do that, you are artificially constrained by the opinions and prejudices of every other party, right, that's engaged in this. So, I mean, let's take it back to the kind of rural practice, right? So, a commonly cited statistic, right, is that there are not enough doctors, right? We need more doctors. There's not enough doctors. There's a shortage of doctors, right? It's either here or it's coming very soon. There'll be a shortage of doctors. If you actually pull the numbers on how many licensed physicians there in fact are, there's not a shortage of doctors at all.
Okay.
There's not. There are enough, even at the primary care level, there actually are enough primary care trained people in circulation to have about, I did the math actually on it once. I think it was 1,000, 1,600 patients or something like that per provider. The issue is one of distribution. Well, it's two issues. One is it's very unpleasant to work in primary care. So a lot of people are looking for the exit on that, right? So they're certified, they could do the work, but and they obviously went through the training to get to the point of being able to do the work, right? So they liked it enough to get through it. Then they get out and they actually put their hand on it and they're like, oh my goodness, this is miserable. I'm going to go work for an insurance company now. I'm out of this. Right? I want nothing to do with it. Or I'm going to cut my patient panel way down because I just can't deal with this. I can't deal with all the paperwork. I can't deal with all the trash, all this stuff, right? I just don't want to have anything to do with it. So they take themselves out of circulation in various ways. But if you just took the broad number of people that have completed all the training and requirements and are theoretically qualified to provide the service, you have enough, even now, for the current U.S. population. This is based on Kaiser Family Foundation data. Like you can Google it for yourself, right, and pull it up and look at the numbers and do the division, figure out how many of them are family medicine, how many of them are internal medicine, how many of them are pediatrics, right? You can go through this. So it's not as huge of a shortage from that perspective, right? It's a distribution. It's a how pleasant is it to do this job problem, but then it's also a distribution problem, right? So yeah, you got all these doctors, but not many of them want to live in Wyoming. And not many of them want to live in North Dakota. So Wyoming and North Dakota are going to have some problem, right, getting medical help. And I use those, but I mean Western, you name it, right? Anywhere that's a little bit more removed from a big city, doesn't have all the amenities, may not have jobs for spouses or whatever the case is, right? All that stuff factors into it. So the solutions that have been proposed are things like, okay, well, we can train more doctors, right? Well, part of the problem with that is you can train more doctors, right? But first of all, when you train more doctors, usually you get more specialists. That's been, like in the past, that's been the experience, right? So you train more medical students, and medical students are like anybody else. They look at it and say, well, okay, so I can make, $400,000 a year as a cardiologist, or I could make $200,000 as a family doctor. We'll both have the same amount of hassle in terms of paperwork and everything else. So, And people do that math all the time, right? And so you end up with more and more and more specialists, but relatively fewer amounts of primary care people. That's one. But the other issue is that you don't even fully have the training structures necessarily to adequately train all the people you currently have. Now you're going to add in more and hope, right, that somehow or other you're going to have appropriate training structures to get everybody well trained. That's a whole different discussion about sort of what medical training entails and what happens when you come out the other end of it. But that's one sort of proposed solution, right? Another proposed solution is, well, why don't we just strip down all the little rural communities, right? Well, they all got all these hospitals out there, right? They can't staff, right? So why don't we just cut them down to like a little ER with a helipad on it, right? Have a few beds for short term or whatever, but mostly, when you roll in there, they'll look to send you somewhere else, right? Well, the only problem with that is the somewhere else's are all full. And increasingly, they're not just in COVID. I mean, COVID has made it ridiculous, right? You can't transfer a patient at all. But even before COVID, right, there were a lot of times you couldn't get a transfer done in a timely manner. So you say, well, okay, so now I'm going to have to keep a person in a place that already was poorly equipped. Now I got to keep them there even longer because I can't get them out to this big center. I guess we could continue to try to expand these centers and make them bigger and bigger and bigger and bigger until they have enough beds, right? But and there's cost in that, there's transport, all this other stuff. And not every problem needs to be moved, right?
Sure.
Some of them could be handled. So an alternative to that would be, why don't we make the doctors virtual and we make the nurses be the hands-on people? Now that's, oh my goodness, like a lot of doctors would hear that and be like, oh, that's sacrilege, right? That's sacred. The doctor must be there in the room. I'm like, well, why, right? Why? What do you really do? Like, really, what do you do from a professional standpoint? Most doctors, surgeons, let's set the surgeons aside because yes, obviously they're hands-on, right?
Sure.
But most doctors analyze data. That's actually the job. The job is, I have a conversation. You come into me with your problem. I have a conversation with you about the problem. I ask you a series of questions. I could do that from anywhere. You don't necessarily have to be sitting in front of me. But even if I needed you to sit in front of me, so maybe there's something visual that I'm going to see, or there's something about your demeanor that I need to see. And that happens, right? I need to eyeball you and see, do you look really sick or maybe not as sick? I can do a lot of that virtually, right? I can see you on camera in the same way. And then I need blood tests, or I need imaging, or I need your heart tracings, or whatever it is, right? All of these things don't require me personally to be there to collect, right? Nurses and other staff are perfectly capable of doing this. Then you go down the line to say life-saving procedures, right? Okay, there's a finite number of life-saving procedures that we do. Yes, doctors are trained to do those things, and they may do them well or they may not do them well, right? There are a lot of doctors that don't know how to do most of those things, actually, right? They really didn't receive much training, and they're not actually that good at it. They're good at other things, right? But the procedures are a hand-eye coordination skill. You don't need to go to medical school to learn how to intubate somebody. You don't, right? Mm-hmm. Intubation being, you're about to die, you need to be put on a ventilator, right? We have to put a tube down into your trachea to get you to hook up to that ventilator and be able to breathe for you. You don't need to go to medical school to do that. You just need to be able to insert a tube into a hole while looking at the thing upside down. And that may sound weird, but it's like you can learn to do it. And we could teach almost anybody with good hand-eye coordination to do that job. Blood draws, right? You don't need to be an MD to do that. Most of the other things that we do, with the exception of maybe some sort of highly specialized, highly complex surgery or something along those lines, you just need a person that has adequate training. They've gone through enough repetitions of that procedure enough times that they know the steps to get it done successfully nearly all the time. And we do this in small increments in various places, right? But for some reason, we've decided that in the rural community, that's not viable. So the model you could easily do is take virtual docs, on-site nurses that have appropriate training, and they can carry out the orders. So you roll into that hospital. I talk to you on the screen. I do a full exam on you over the internet, which is fully possible at this point. And I say, okay, nurses, I'd like these lab tests. I'd like these imaging tests. Oh, we need to do this procedure. Oh, Mike has a fluid collection here. Can we stick a needle in that and drain it and send it off for analysis, right? And the nurses could easily be trained to do all of those things and do them very well, but we just don't, right?
Well, and when there are more advanced procedures that need to be done, a lot of times there's prep time. It doesn't happen on site right away.
Yeah, it does. But most of the life-saving procedures, like the really emergent things, right? Yeah. Again, you're going to roll in there and you need to have this done right now. We can teach people how to do that stuff, right? Okay, we're not going to do your bypass surgery there.
Yeah.
But we weren't going to do your bypass surgery there anyway. You know what I mean? Like that,
Exactly.
we were going to first identify that you needed a bypass, and then ultimately we're going to move you on to the place that does the bypasses.
But do one trip.
Yeah, exactly. You do one trip. And so you could take those same places and give them better diagnostic equipment, which is really what they need. A lot of them are struggling with that, right? They can't get their CT scan is 30 years old. They have ultrasound once a week, right? They can get MRI maybe once a week when the truck rolls by, right? Do you see what I'm saying? So why not, instead of paying $500,000 a year to have a family doctor move out there and cover 50% of the schedule, why don't you instead buy an MRI machine, stick that out there, right? Train the nurses to do procedures, have the doctors be all virtual, right? So that they can also be instantly available, right? You don't need to wait for the current rural hospitals, you need to be within 30 minutes when you get called, right? It's like, but in that 30, you could be dead in that 30 minutes, right? But I could just have a doctor that instantly is available on screen, right? Can see me, start giving orders and issuing the things that need to be done. I can have staff that are trained how to do that, a small number of people that's a totally different model for doing this, but it's something that absolutely can work. It will be more cost effective in most cases, right? And it doesn't necessarily have to have any decrement in actual quality in terms of the outcomes of what goes on, particularly as compared to right now. Because what happens now is, well, we got to have our emergency room, right, covered by a provider. Well, there's not a lot of providers that want to come out here. Well, basically, let's just get whoever out here, right, that fits the bill. Whoever it is. Doesn't matter whether they have a lot of experience in that, doesn't matter whether they have a lot of knowledge in that, right? There's really no requirement for that. As long as you have the certificate on the wall that says you're qualified to be in this position, that's fine, right? That's how it's done, because it's just who's available right now. And take any given small town you want. The list of people that are available to go to that place is already small from the beginning. Cut it further down to who really wants to go there. It's much smaller. And then cut it even further down to who's at the right place in their life or in their schedule, or if it is to go right now.
Well, and that's the doctor you're talking about. What about the spouse?
So again,
what about the kids?
Cut that even further, right? I mean, it just keeps dropping.
Right.
So you're down to a very, very small number of available candidates, right? But take that same town and say, hey, graduating medical students or graduating residents, right? I have a town in rural Kansas, right, that needs a great doctor. We would need you to be available during these hours and during these times, right? You won't necessarily have to move there. So you can continue to stay where you are, and your partner can work in whatever their job is, right? And you can do whatever it is you need to do with your children or whatever the case is. But you're going to be this town's doctor. You're going to be there all the time. And we're going to back you up with on-site staff. And sure, okay, so maybe, we understand, right? From a psychological perspective, from a rapport perspective, right? So you're going to go out there every now and then, right? And be there and see people. Right, fair enough, right? Okay, that's all fine. But most of the time, you will not necessarily need to relocate to be there. You know how long that list will be? Much longer.
Oh, yeah.
Because a lot of those residents, that's exactly what they want to do. They're like, yeah, I got into this to try to help people that need service, right? That's what I wanted to do. And now you've given me a way to do that that doesn't require me to necessarily move out to this place, right? Or, have my partner put their career on hold or whatever the case, right? It doesn't require that from me. Now I can do it. And then add to that, just at the primary care level, add to that all the different specialties and all the other things that are there, right? And rather than the current situation, which is I roll into a small town, I get, for the most part, the expertise of whoever it is that's there. If they're excellent, great. If they're not so excellent, tough for me, right? I don't have, and to be fair, they don't have any backup either, right? There's no additional resources beyond what they have. And so here again, you talk to quality of care. What's the difference between getting care, let's say at Wesley or St. Francis, versus getting care in a small hospital in rural Kansas? In reality, right? The difference is two things. One is the number of resources that they have in that larger facility.
Sure.
Right. But many of which at the lower levels you could replicate in the small environment. It's machines, right? It's machines of some kind. And then the second is the experience and collective experience of all the people involved in your care, right? So it's that doctor that you're seeing sees, just for the sake of argument, they see 20 people a day, right? And 4 times a week, someone with your problem rolls in. So when you roll in, they're pretty familiar with your issue, right? Now, if I take you out to the small town, someone with your problem rolls in once every 4 years, right? Who do you think is best equipped to make quick and accurate decisions, right, about that particular problem, right? But the other difference is that, let's say you roll in there, and let's say you roll into one of the big hospitals, and the doc looking at you says, this is a real weird case. Like I don't know what this is. It's not what I thought it was. Something's weird here. They immediately have 15 other people around them also looking at your case, or that they can bring on to look at your case. Not just other doctors. There may be pharmacists, it's nurses, there may be respiratory therapy, all these other people, right, that are engaged in your case. All of whom are bringing to bear their years of experience on your situation and hopefully, ideally, communicating with each other about it, right? So rather than you being out there in full isolation, you get the benefit of those collective years of experience. And there are many cases that I can cite and others where those things made the difference, right, in terms of the outcome, what the patient actually experienced. So again, point of this is not just to kind of talk about new models, it's to say, there's a model here that has some substantial arguments in its favor.
Right.
But you can't get through the walls of blockages, artificial blockages, right? It's not like hey, we're being allowed, let's roll this thing out and see how it competes with the existing thing, right? It's like you can't even get to that point because of there's regulatory bodies, there's CMS, there's, the opinion of whoever it was that, has never thought of it this way. And it's just, and all of them say, nope, 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 can't do it, right? You can't even start. You cannot do this. So there's no ability to take the thing and actually let it run and assess it on its merits in most cases.
Well, the good news is that you have a hybrid cash insurance model today, which is your faster horse. Because I appreciate I can come in and pay cash for certain things and get a much better rate when it's at cost.
We do. There's more infrastructure, right, that we need to develop around that. That's the biggest thing. And I think that I think gets you to the car, to continue the analogy, right? It gets you out of this sort of faster horse mode where you're slightly more efficient to something that's genuinely a departure from what we're doing now.
Right. So maybe if you get the Buffett Amazon healthcare thing
died. They shut it down.
Right.
Yep. Multiple. That's what I'm saying. Right. Multiple large corporations have tried to come in.
Is that what they were shooting for?
No, I'm not clear. I mean, I wasn't on the inside of that by any means.
Not in on that.
We
could certainly try to tap Buffett for something.
Got him on speed dial.
Yeah.
Talk to him and see. No, I mean, I think they were trying to make some changes. At least again, I'm only reading media reports, so for what that's worth, I think they were trying to make some changes in terms of how they're providing healthcare to their own employees. But it seems like in the end they weren't able to get there, and for whatever reason they shut the thing down for a few years, 2-3 years, something like that. It wasn't that long.
Yeah, they were trying to do, I think it was prescriptions too through the mail, cut down on costs. So somewhere in between what people do with Canada and what we have today.
That's a whole, I mean, as you already know, right? There again, it's a whole, the generic, when we started getting the pills, we had, I'll never forget this actually. At the time, we got a 30-day prescription for metformin, which is a common diabetes medication, right? It was $4, right, at Walmart. And when Walmart launched the $4 list, like within medicine, we all thought, oh, this is fantastic. Like, this is great. Like medicines that our patients can finally actually afford. Then we went and bought a bottle of 1,000 metformin, which at the time cost, I think, $3.50.
Okay.
So we're like, okay, wait a minute. So you're handing out 60 of these for $4. We just bought 1,000 of them for $3.50.
Wow.
There's a problem. There's a problem. Like there's a disconnection. And again, you can make arguments about business models and structures, whatever, and right, I have no insight into what Walmart's economics are behind this, although I'm guessing they get those pills for cheaper than we do. It's that question of, right, if you could get the cost of this that low, why would you not do that?
Right.
Why would you not do that? And I say that because we act like healthcare is a luxury good, but it's not. You know what I mean? It's not. We're not selling Ferraris here, where there's like, I don't know, there's a few million people or whatever that can actually even afford one in the first place, right? And so the higher the price is, the better the status is with you know what I mean? Like it's not like I'm like this is the thing that like everybody. There's like tens of millions of people with diabetes, just in this country, right? There's hundreds of millions of people around the world. At the very least, I don't have the numbers in front of me, but it's a ton of people. And guess what? Most of them will need metformin at some point, and they will need it for a long time. And guess what? After them, there's a bunch more still coming, right? Because we're all still overweight. It's like, So why wouldn't you figure out how to put that at a price point that people could afford, rather than the current situation, which is, oh, I'm so sorry, you can't afford your medications. Well, here's what we'll do. It would have cost us, pennies on the dollar to make these things affordable for you. What we'll do instead is we'll let you lose your job because you can't feel your legs anymore, because your diabetes is out of control because you can't afford those medications, right? And then later society will pay to amputate your leg at this point, right? Rather than just making the original price point of the thing that would actually control your disease affordable.
Yeah, I wonder, and I realize government keeping their hands out of business is one thing, but when it comes to the viability of health for the country, I would think that's got to kick in at some point to where there's accountability around what something truly, truly costs and what they're able to charge for it. Because going back to the food analogy, now food can be very inexpensive to manufacture, but it does not have the kind of multiples medicine does. Yeah. Prescriptions, all that stuff. Yeah.
Agreed. Yeah.
Because there's different market pressures, but they've managed to silo it in a way and use insurance as a buffer to keep that information quiet and be able to charge it. So at some point they've got to step in and bring that down.
I would assume, and I don't, part of the problem also within healthcare is that every area is kind of its own thing. In other words, being very knowledgeable in one area, sometimes there's details, right, that go on in some other area of healthcare that you don't even know exist, right, until you get way down in the weeds in it. Medications are probably another one. It's all kind of, there's pharmacy benefit managers. There's a whole just layer of stuff that you need to know specifically about pharmaceuticals to really understand how the whole system works and why it was built that way and why it does what it does. I am not an expert in that area, but what I can say, what we do see routinely are people being harmed by the extremely high cost of medications. I can also say that we did interact with the sort of regulatory structures in our own work with the rural telemedicine, and it was really overall a disappointing experience. I mean, at one point, we got to sit down with the regulatory body, in this case it was CMS, and we had a meeting with them, and we said, here, they had some regs on the book at that time that restricted our ability to provide the service. But I'll spare you the details on it, but it made it so that for no reason, we were not able to do everything that we could do because there were certain restrictions that Medicare had written in. This was written in years before any of this was even possible, right? So it was one of those times where there's a legacy law or legacy regulation that's blocking an action that wasn't even contemplated at the time that was written.
Right.
So we go to them and say, hey, folks, here's what the problem is. Here's what we're doing. Here's what we can do. Here's the positives that it brings about. There really aren't a lot of negatives that we're able to find, but fair enough, we can discuss those if there are. What do you think? And we get to the end of the meeting, and they would say, oh, this is great. We love what you're doing. It's fantastic. It's wonderful to hear about all this progress that's being made. Oh, great. Okay, so how do we change this regulation? Yeah, about that. None of us really know how to do that. We can't change that. Here's an email address. Email this guy. Email him. It goes to a black hole, right? You never hear back again. Interestingly, when COVID hit, particularly when it got around DC, all of those rules that were quote unquote unchangeable changed
overnight
within 2 weeks. So, I mean, I think my point in that story is that we sat down in front of parties, we presented our information. They didn't have any pushback. It wasn't like, if you do this, here's the unintended side effect of your action. It's going to really mess stuff up. It wasn't like that at all. It was, we really have nothing to say. We agree with you. It's all true. Yep, right on, Except for okay, now please change this. Well, no, we can't do that. Except that we can when we want to. I don't understand all the incentives that go on behind how those decisions are made. But I can say that on a practical basis, as an on-the-ground, frontline type person, we saw what the negative repercussions of their unwillingness to change that regulation were, and we saw the facility with which they changed it when it became convenient for them to do so. You know what I mean? And that compromises your faith in are you just the umpire? You know what I mean? Are you the umpire? You don't care who wins this game, or are you not? I don't know. Again, I can't comment really on their motivations. I can only comment on the outcomes of the actions that they took at that time.
Sure. Yeah. Well, I guess the good news is, at least today, a lot of that red tape's been cut.
Much of it, yeah.
And it's a lot better than it was.
Way better than it was.
So it took a pandemic to be the push they needed, I guess, to get on the same page.
Well, locally, it took some civic action. I mean, we had to go to the State House, right? There were some laws we had to testify about and debate over. Some laws got passed.
Right.
So there was local action in Kansas first, actually, before there was any pandemic, and then the national walls all came down when the pandemic hit.
Right, the Medicaid type stuff.
The Medicare stuff changed dramatically after COVID. Before that, we were still somewhat restricted. But Kansas fixed the payment issues a few years ago, actually, and there was a rep from Wichita that was pretty involved in that process, at that time, and a lot of other people also that helped in that process. So there's some hope, I think, for kind of local or at least state level civic action. Like you can still get some things done, hopefully, in that context. But yeah, I mean, healthcare is a multi-level beast. So,
what would you say are either the one or two top entrepreneurial lessons you've learned from building Free State Healthcare?
I would say the positive lesson is that persistence, which they were calling in the sort of the pop entrepreneurial literature, grit. There's some truth to that. There is some truth to that. Because I think unless you get very, very lucky, almost nothing goes the way you plan. I did, I don't know, 4 or 5 different pro formas. I had it broken down into just eye-watering levels of detail in terms of how it was going to go, and I had very realistic, growth patterns. They were extremely conservative, and I was like, this just works, right? And then what actually went on had nothing to do what was on the pro forma, or all kinds of things, went sideways in ways that I don't know how you would plan for. I mean, maybe, I don't know, maybe if you were really experienced at starting businesses and you'd done it 50 times, you'd know, but otherwise, no, it was not. And it had nothing to do with having the best idea or even having it early enough, right? There were all kinds of other factors you could account for. So pushing through all of that requires a level of persistence and commitment to the thing that you're doing, particularly if you don't have massive capital stores to sort of help you ride out that period, So that, I think, is one. I would say probably the other lesson, for me, I think in the end, probably goes back, right? There's a well-known Bible verse, right, that says, the race is not to the swift nor the battle to the strong, but time and chance happen to everyone, or happen to all of them. That's kind of true. So much of it is still, I mean, it's like, the process of generating an idea and trying to build around it is interesting and exciting, but so much of what happens just comes down to your timing. And a lot of your timing, you know what I mean? That's that sort of luck element of it. If you hit the thing at the right time, you may succeed. If you hit the thing 5 years too early, it may fail. It doesn't mean your idea was wrong. It just means you're in the wrong place at the wrong time.
Yeah. TiVo.
I think there's a long list.
There is a long list. Right. That's a classic
of
one.
Frustrated people. Tried to tell you.
It was the perfect thing, but, nobody else had truly caught up to it.
Yep.
Yeah.
That's,
throughout this process, how do you, I know I've heard the healthcare industry is rather miserable right now.
Yeah, that's fair.
With the demands that are placed on everybody, that's all hands on deck with the COVID.
No hands on deck, actually, that's the problem. There are no hands left to be on deck.
Yeah. How do you take care of yourself? How do you live the best life possible? How do you have a high quality of life for yourself? Because this may be a season where it's just hard.
That's the best way to describe it. Yeah, it's just miserable, and there's not I don't know what to do. You know what I mean? It's like the everything is full, right? Every facility is full. The patients are sick, both with COVID and non-COVID. They're sick, but COVID patients are they're just a different kind of thing in terms of what goes on with them. It's different than anything that I have experienced in my career. I would say, even speaking to physicians that are several decades further, I don't think even they've experienced much like this either. Even HIV wasn't quite like this. I mean, HIV was obviously another, severe infectious disease, but just a different thing in terms of how it progressed and the timeframes over which it operated. So we're in an era when people are sick. You don't have the help. Your own colleagues are getting sick themselves and being out for a certain amount of time, and a lot of people just quit. The early retirees are retired. A lot of the younger people are like, hey, I think I can work at Walmart for about the same money. Why would I do this, right? I'm putting my life at risk every day, I don't get treated that well in the first place. So, I'm just going to go do something else. So we have a lot of that going on. And so it's left an increasingly smaller crew of people at every level. Now, I'm not just talking about, actually the doctor level may be the best staffed at this point. There's like no nurses. There's, we struggle to get respiratory therapists, lab techs, you can't get them, the housekeeping staff is decimated. It's just every level, right? You can't get people, and they can't stick around because they're getting sick. They're out. All kinds of stuff is happening. So you take a already high stress thing from the medical perspective in terms of what illnesses are there and what time course do they operate on, and then add to that the shortage of everyone and everything, and then add to that the supply chain issues where you can't, you're running out of drugs and you can't get this or that thing. And it's just a very, very high stress period for everyone. And if anyone has figured that out, they're keeping it very secret. Because it's not, even the reports from colleagues and friends and even publications from other places, it seems like everyone is experiencing the same misery.
Okay. Was there at least a lull here in Kansas between the waves of right now the Delta or the
Yeah,
Omicron?
Omicron's starting to take over. Yeah,
Yeah.
we were actually a little late on Omicron as compared to a lot of other places. We had more Delta hanging around than that. There was a lull, I would say the biggest one was in the late spring, early summer. It started to go down. By the late summer, it started to go up. You might have had a little dip in the early fall, but then it just rose and just continued to escalate. This week is the first week in months that we have seen where it seems like case numbers are starting to come down a little bit.
Oh, good.
So whether that will be a pattern or not, I don't know. Whether we're going to have another wave when Omicron kind of installs itself all the way, I don't know yet. The epidemiologists probably know that better, but that's what we're seeing at least this week. So, positive news.
Yeah.
We could use it.
Light at the end of the tunnel, hopefully.
We hope so.
Yeah.
We hope so.
Wow.
But it's, it's going to be the whole problem. I mean, everything about that. Just as a disease, it's fascinating. It's fascinating from an objective, kind of scientific perspective. It's fascinating.
Don't forget to tip your doctors.
Tip your nurses, actually.
Your
Tell them to
nurses,
please stay.
Yeah. No, I hear the kind of hours and the kind of, because, it seems like it used to be that if you're a nurse, you would have natural breaks and, ups and downs. But from what I understand is it's just constant go right now.
Yeah.
And it is exhausting.
Yeah. Well, I mean, it's, I can speak from the doc perspective, and which the nurses are in similar boat, right? It's like, hey, you're okay. Oh, great. You work. Okay, I'm going to get a weekend off. Oh, the person that was supposed to be on just got COVID, right?
Right.
So now we got to,
And then all the home life stuff that goes with that if you have kids.
Absolutely, yeah.
And trying to figure out care for your own family.
That's the case, If you're people in your house, if they're getting ill, even if they're not, their teachers are getting sick, their schools are may have to shut, or even just the stress of knowing that you're coming in and out with a disease, right? That might kill a relative or something like that, right? You have to think about that every time you come home. You got to try to make sure you're washing yourself off. You're trying not to spread it. All of those factors are going on all the time, plus the fact that when you're in providing care, you're also constantly conscious of the fact that, hey, there's a disease here, it's legit, and this thing is not entirely predictable in terms of who it harms severely. It's not I'm younger and I don't have a lot of chronic health problems, so I'll be fine. I mean, on average, you'll be fine. But we got plenty that looked just like that right before they died, So it's not not straightforward.
And it's a slow process usually.
That's one of the things that's not commonly talked about, at least in the media, is that with a lot of so there are other viruses, right, that'll kill you, sure, right? But they'll kill you quick. They will, they'll get in, and if you're going to get that sick and you're going to die, usually it'll happen relatively quickly. We'll know. With COVID, even if we know, even if you come in and we're like, oh boy, lots of chronic health conditions, not in good health, very high risk to die, it may be another week. It may be 10 more days before the hammer finally actually drops, right? And during that whole period, we're scurrying around doing what we can do. But by and large, a lot of what we can do doesn't make that much of a difference in the outcome, And so we know what's coming, but it's going to just sort of get here when it gets. So my point is that during that whole period, right, you're just sitting there. You're just sitting there, getting a little bit worse as time goes on, a little bit worse, a little bit worse, a little bit worse. And that bed is tied up for that entire period, right? And so not only is it tied up in your care, and that's not a bad thing, but it's that bed used to turn over in 2 days, right? Or 3 days. Now that bed is tied up for 10 days. It's tied up for 14 days. It's tied up for 21 days, right? This is even if you didn't die.
Yeah, so the patient count may not be the real metric that's the issue.
Not. Yeah.
It's just so much longer per patient.
Much, much longer. Yeah, I mean, you have flu, right? Flu will make you sick. On average, it's about 7 days-ish, right? You know what I'm saying? It's like, but if you ended up in the hospital, you'd be in the hospital for a couple of days, right?
You have heart surgery, you're out
exactly,
pretty quick.
Exactly, right?
You have a human come out of your body.
Right, yeah.
A day,
they're in a day, right? Exactly, right. And, you come into us with come into us with a bacterial pneumonia, right? On average, we're going to have you out in 3-4 days at most, maybe less than that, right? It might be a day or two. A lot of conditions are sort of in that wheelhouse of, 2 to 5 days. And then bam, we have this thing here, and you sit there for a week, and that's if we're lucky, right? I mean, truly, we've had patients in the hospital for a month, and that's again, they're not even, they're just failing to improve, right? They improve to a certain point, they stop improving, and we're just stuck there waiting until they clear certain thresholds to even be able to go to a lower level of care.
Right. Yeah. And we're talking about like ICU beds.
Absolutely. Yeah, that's right. Yeah, they're too sick to not be in the ICU, but they're not getting worse. You know what I mean? But they're also not getting better. And so you're like, well, we cannot move them out to the regular floor. We also cannot move them to anywhere else that could provide step-down care for X number for these reasons, or because they're full too, right?
Yeah.
So we've just tied up an ICU bed for 3 weeks. And during that time period, a lot of other people also came in with ICU-worthy stuff, and we couldn't fit them in here.
Yeah, like you mentioned, you had a patient that had a heart attack that couldn't get the care they needed.
Multiple times. They had a significant, like not they're what we call kind of quote unquote mild heart attack. There's technical terms for all this stuff, right? There's sort of mild versus really severe, like life-threatening heart attack, where we've had people with that kind, the really severe kind, that normally they have beds reserved for that, right? In this hospital, you call and you get a bed almost instantly. No beds. You just sit them there and look at them, and you give them some IV medication, right? And you say, well, I hope this goes as well as it would have gone if we could have gotten you to definitive therapy, but we can't, right? We've had deaths over this. We've had people literally die from a thing that we could have fixed. It's like we could have done surgery on you and fixed this. You would have walked out of the hospital alive and fine, and you died because you were stuck in a place that didn't have the resources to care for that problem. You had no way of knowing that when you rolled in. Nobody knew what this was, right? And we should have been able to transfer you in plenty of time to do this, but guess what? We can't anymore, and now you're dead. And you didn't have COVID at all, right? It was some other just bad luck thing that happened to you, right, during this period. So all of that is going on in the background of all of this, right? And you can just imagine, right? The stress, the psychological stress, right, on people. I mean, just the stress of watching people die from a thing you could have fixed. Even if it's not your fault. You know what I'm saying? It's not like you did something, but it's like, it's
a tough pill to swallow.
It's rough. Like it's difficult for people to reconcile that.
Yeah.
But that's what's going on.
Wow. So obviously, if you pray for your medical friends, physicians.
Yeah, please do. Yeah.
And what are maybe some practical things people can do to help out their friends that are in the medical community?
I think, one is, words of support, right? People, at this point, different people respond to it differently, but I don't think it hurts. And I think it can help because some folks, are really beaten down by it. And that I think can be helpful to them. If you are a patient, if you have to seek medical care at this time, I would say a couple of the things. One is that trying to not go in for low-level complaints, like finding another way to, whether it be calling your doctor's office or finding another way to handle that, actually is genuinely helpful because they're getting just buried in people right now. Everyone is, right? So if they can save some of those problems that, I'm not saying they're not significant, but they're not as life-threatening, they're not as urgent. If you can do that, that's helpful. And then I would say that if you do need to seek care, just kind of understand from the outside, right? These people are under a lot of stress. They're often not getting adequate rest. It's not even close. They're working way too much so have some amount of just mercy on them, right? And if they're not immediately responsive or if they're not in the best mood at the time, I'm not saying you should accept abusive behavior or something like that, but within reason, right? It's like just extend them some grace and understand that right now, everybody in there is in some level of misery, and they're doing what they can, often with resource limitations that you don't even know about that are going on. They called for the med, and you're mad because you didn't get your med. Look, they called for the med. The problem is that there's one tech down there. You know what I mean? There should be 3. There's one. They're trying to handle all that stuff. It's going to take them 3 hours to get that med upstairs instead of the half hour it used to take, right? Just, the labs are not going to get done on time because there's not enough lab techs, right? So everyone's trying to do what they can do. They're all constrained. So have mercy on them in that, in that time period.
Yeah. Yeah, that's a good word. I think we probably all could help have a little more mercy on others in general, but especially now and with medical, despite how frustrating it can be to feel uncomfortable, feel like you're owed care quickly. But yeah, a couple 100 years ago, you'd be lucky to have a doctor you get a hold of at all, right?
You would, yep.
Yeah. So we live in a phenomenal time, and it's easy to take it for granted.
Yeah, very much so. No more riding down the road on the horse to get to your farm.
I mean, there's people who are committed to that.
Yeah, no. But you don't have those delays anymore. You have a very different expectation.
Right. Well, very good. Well, thanks for coming on and taking some time from the chaos you're operating in and sharing with us a little bit about your practice, the state of things, and giving us some perspective on how we can be supported from our end and live a little more mercy and grace today.
That sounds good. Thanks for having me on. I appreciate it.